Hello, I'm Guruprasad Aithal and we'll be talking about drug-induced liver injury in the next 20 minutes. First of all, we will have to define drug-induced liver injury as I will be using that term in this talk. For me, acute drug-induced liver injury is a form of injury which is acute in onset, occurs in those who are taking medication in a therapeutic dose. The injury is attributable to the drug intake or exposure, and it's not predictable by any known pharmacology of the drug. I try not to really distinguish between intrinsic versus idiosyncratic drug-induced liver injury, as it's not very distinct. You probably know that even liver injuries which are considered idiosyncratic, there is an effect of a dose of a drug within the therapeutic range that influences occurrence of a DILI. Overdose is not part of my talk as it's easily recognizable. Its pathogenic mechanisms are entirely different compared to idiosyncratic drug-induced liver injury. Drug-induced liver disease is a term which encompasses all forms of DILI as well as chronic diseases which are attributable to drugs. And hepatotoxicity is much less precise term, includes environmental toxin. So we will focus on idiosyncratic drug-induced liver injury today. Challenges in clinical practice is that over 650 drugs have been reported to be associated with drug-induced liver injury. Signature pattern of this injury isn't as distinct as one makes out to be, and it is most of the time indistinguishable from the other forms of liver injury. Increasing prevalence of comorbidities, especially with the metabolic syndrome, fatty liver disease, it's becoming even harder to separate out acute liver injury when it is mild to the fluctuation that one sees in a fatty liver disease. Polymorphism also is increasing in association with comorbidity, which makes it harder to identify a causative agent. Diagnosis of liver injury due to drugs has always been a challenge because of heuristics. These are strategies that we use, shortcuts that we use to come to a diagnosis, and they're not really very applicable or effective in drug-induced liver injury diagnosis in particular. And there are new tests available, but we seem to set a very high threshold to use this test, and that also contributes to our challenges in relation to identifying and managing drug-induced liver injury in clinical practice. First thing to diagnose drug-induced liver injury is to consider it. This is one of the studies done in France in a hospital setting where you would think that there are experts who have specialist interest in areas of liver disease. They took 6 months period within the hospital where standard practice is a person develops acute liver injury and the physician looking after the patient identifies that this might be related to drug, and patient is referred to a specialist hepatologist, and they are in the discharge diagnosis. When they looked at 6-month period, they found 12 patients with drug-induced liver injury among 28,000 plus inpatients. So they calculated the incidence of drug-induced liver injury in that hospital for that period. Then they took what is called a proactive strategy. For a week's time, there is a group of 3 specialists, 1 clinical pharmacologist, 1 biochemist, 1 pharmacist. and a hepatologist joined together, formed a group, and all patients who had ALT more than 3 times upper limit of normal, which they took it as a cutoff to look for acute liver injury and its causes within the hospital setting, were reviewed by a group of 3. Like I said, specialists, a pharmacist, and a clinical pharmacologist. Then they invited themselves with ethical approval to see these patients in the wards and went through the details of their workup and eventually confirmed the diagnosis of drug-induced liver injury. They came up with the incidence of liver injury in this setting, and they found that they increased the daily incidence by 12 folds, which is consistent with previous studies to highlight that only 10% of significant drug-induced liver injury are generally reported. It also highlights that if you don't consider drug-induced liver injury, then you will never really make an effort to diagnose it. This is another relatively recent data, now about 8-year-old, comes from another hospital, secondary care hospital, England this time, where there are pathways of patients referred by a primary care physicians with jaundice to be evaluated. So they took over 2,000 cases referred through that pathway and found that 58% of them had biliary obstruction. So, which means that 42% of jaundice are not related to biliary obstruction. And these they called as medical causes of jaundice, and then investigated them and delineated what the final diagnosis were. If you look at this, these are jaundice, so generally you assume that they might be acute or recent onset. Drug-induced liver injury was the second common diagnosis in the groups where biliary obstruction has been excluded, only second to decompensated cirrhosis. All the other acute liver injury etiology one considers, what comes to mind, which generally most clinicians try to exclude, were less common. Viral hepatitis, for example, all viral hepatitis, acute, including A to E, EBV, and CME together, was 10%, much less than drug-induced liver injury. Autoimmune hepatitis, which again, another etiology which most hepatologists certainly want to exclude, was 5%, a lot less than that. This is to highlight that when you look for it, drug-induced liver injury is much more common than one would think. If you look at population-based study, which calculated population incidence of drug-induced liver injury indirectly in China. This is closer to Asian context. That's why I have picked this up. And it's also the most recent literature published 2 years ago. And finally, I was involved in designing this study and advising them in interpreting the data. So I know this study much more closely. They took out discharge diagnosis of patient in the hospital. They formed a group and identified these cases, and they themselves evaluated and confirmed whether these were acceptable diagnoses or not. So it's not really very structured evaluation, but broadly taking up the study drug-induced liver injury diagnosis at its face value. Then they calculated what proportion of population were in these hospitals. This was done in 66 centers over a short period of time, and calculated what the incidence of drug-induced liver injury per 100,000 population per year came out to 23.8 per 100,000 persons per year. If you look at European definition of rare diseases, this considers anything which is less frequent than 1 in 5,000. So by this definition, drug-induced liver injury is not even a rare condition. Then etiology of what drugs cause and contributes to this liver injury. Again, might be relevant to Asian context. In China, it is complementary medicine. And this is a form of treatment which might be prescribed where evidence of efficacy is lacking. So in my view, this is much more problematic than drug-induced liver injury, where we have efficacy at least documented. Anti-TB drugs, I'll highlight a few information relevant to anti-TB drugs. Anti-neoplastic and immunosuppressive agents, these are life-saving drugs, so we may need to accept this. Anti-infective agents, even a short course of antibiotics, and psychotropics, were the common etiology behind this. Some of the pitfalls in our diagnosis is to identify what is truly relevant when there are a number of salient findings in the case. This is what I call an entry point, which means that you need to set out certain criteria more important than the others, and that comes by experience. Just simplifying it, how do we recognize an acute injury? This is by keeping ALT level more than 5 times upper limit of normal. I'll just explain it another way. If you take large randomized controlled trial where inclusion criteria is so rigorously looked at in that by and large, people with chronic disease are taken out, and then look at the placebo group, how often one gets more than 5 times upper limit of normal of liver enzymes, where you know this is not due to drugs, means that unexplained raised liver enzymes of this threshold occurs about 0.3 to 0.4% in 100 patient years, which means that if you reach this level, you should have an explanation to it, and you need to investigate it. So if you take this threshold, then you would really not compound your data with lots of non-specific elevation of liver enzymes, which may be due to changes in lifestyle or underlying chronic disease, which hasn't been picked up. Then if you increase the threshold above that, higher the threshold, the kind of etiology that contributes might change, but frequency of drug-induced liver injury still remains about 9%, which means that more than 5 times upper limit of normal is a very good threshold to take. Same way, anything more than 2 times upper limit of normal alkaline phosphatase in the absence of obstructive jaundice, like you saw in the population-based study in UK, also confirms that this is where one need to look at the drug-induced liver injury as a potential differential diagnosis. Why else this threshold might be helpful? I showed you that in Asia, anti-TB drug-induced liver injury is very common. This is one of the randomized controlled trials testing 3 different standard drug regimen. It's the same 4 drugs used in different ways: INH, rifampicin, pyrazinamide, and ethambutol. Inexpensive drug, very effective drug, still used even in a setting of drug resistance, as they still are the most effective drugs. The one factor which reduces their effectiveness is drug interruption more than 7 days. This randomized controlled trial showed that drug-induced liver injury is the commonest reason why there was a drug interruption. So we performed a large cohort study in China recently. We had 3,155 people who were exposed to standard TB regimen. 6.9% developed more than 3 times upper limit of normal. And we observed that 88.5% of them did not need drug interruption of anti-TB drugs, which they were on for more than 7 days. Some of them needed some interruption for a few days and then restarted, which means that effectiveness of the drug is still retained, and only 25 out of 218 who developed more than 3 times upper limit of normal progressed on to 5 times upper limit of normal, and none in this group developed acute liver failure or died. So when you're considering a critical use of drugs like anti-TB drugs, it's reasonable to keep the threshold of 5 times upper limit of normal as the marker when you must really interrupt the drug and then test whether there are alternative explanations to it and make a diagnosis and then have a strategy of reintroducing a drug. The tests which are available are overused without putting context in the costs and performance characteristics of the drug, while tests such as genetic tests, which will support the diagnosis of drug-induced liver injury, are underused. And this is a table of a way of looking at performance characteristics of the drug. I mentioned that the second common cause for jaundice, once obstruction is excluded, is drug-induced liver injury. The commonest cause in UK is decompensated alcoholic liver disease. You hardly ever confuse it with drug-induced liver injury because ALT very rarely goes above 4 times upper limit of normal in decompensated alcoholic liver disease. So while 5% of the time you get autoimmune hepatitis, but anyone who has got raised liver enzymes, irrespective of what level it is up, are going through these tests, which have got a performance characteristics which are generally overrated. If you see here, those who had autoimmune hepatitis, about 75% maximum had ANA positive, about 59% had SMA positive, IgG was elevated in 86%, LKMO was positive in 20%. While if you look at the normal population without any autoimmune diseases, 24% above the age of 40 have got ANA positivity. 43% of the normal population have got SMA positive. So in reality, these tests in combination might support the diagnosis of autoimmune hepatitis, but not with the strong performance characteristics. We still use it routinely. If you compare this to HLA tests to confirm or support the diagnosis of drug-induced liver injury, let's say comoxiclav, you saw antibiotics are third or fourth common causes, even in Asia. Comoxiclav, this genotype is present in up to 70% of patients with comoxiclav-induced liver injury, present about 15 to 20% of the population. So it's comparable to ANA, but we don't even do it, even in a small proportion of people where the diagnosis is in doubt. I'll show you what happens if you don't confirm the diagnosis and how it might impact patient care and the diagnosis. Flu-clox-induced liver injury is as good. B*5701 is as good a test as immunoglobulin levels. So cost is often attributed as the reason why these tests are done. I put in a cost in UK for whole autoantibody profile, including immunoglobulin in UK, is 21 pounds. HLA typing done once, not repeated any time in your lifetime, is 35 pounds. So we need to reflect upon what the tests are for and how they are used with putting true performance characteristics before we can make the choice of the test. I'll give you two examples of how HLA tests can support the diagnosis. These are two patients who are similar presentation, and you will see the message. This is an 84-year-old woman, had acute pyelonephritis, presented with jaundice, bilirubin 6 milligrams already, hepatocellular pattern of liver enzymes, no biliary dilatation, full range of hepatitis serology negative, ANA positive, immunoglobulin is high. You would think autoimmune hepatitis. This is the profile of drug exposure. Patient had 2 doses of nitrofurantoin before the onset of liver injury. So nitrofurantoin with other drugs were a possibility as a diagnosis, as an etiological agent for drug-induced liver injury. Liver biopsy was done to exclude autoimmune hepatitis, which had some features of autoimmune hepatitis. There is interface hepatitis, which is severe. There is rosette formation, which again talks about severity, and peripelipoiesis, very uncommonly reported a histological phenomenon, again attributed to severe autoimmune hepatitis. But there was no fibrosis, and there was some focal cholestasis. So this raised a possibility that this might be drug-induced liver injury. We did a HLA typing. This HLA typing is something which is present in about 30 to 60% of patients with autoimmune hepatitis, which was negative. So our diagnosis was that this is nitrofurantoin-induced liver injury. So we did not start patient on immunosuppression. Patient resolved. 1 year later, patient has not had any relapse of any acute event. This is a patient who is 77-year-old woman, similar background, has dyslipidemia, and has been on atorvastatin, 40 milligrams, which has been there for a while. So long exposure to atorvastatin in a high dose. So there was a bit of a doubt whether it is actually drug-induced liver injury or a bona fide idiopathic autoimmune hepatitis. ALT very high, so hepatocellular pattern, normal ultrasound, negative virology, absolutely negative immunoglobulin profile, negative autoantibody profile. So nothing to support autoimmune hepatitis. Liver biopsy has got some features, less intense than one you just saw, moderate degree of inflammation, plenty of plasma cells, lobular inflammation, some lobular hepatitis, and interface hepatitis, but no fibrosis. Again, equivocal findings, negative serology. This patient had atorvastatin withdrawn, liver injury improved. So you would think this is drug-induced liver injury, but patient was on follow-up, developed second flare-up of liver injury. You can see the pattern in this diagram because we kept the patient on follow-up because patient had ERB1 0301 positive. As I mentioned, is suggestive of autoimmune hepatitis, and patient was started on steroids and then this resolved. So it's important for the patient that we identify an accurate diagnosis in the long term, as well as do not expose patient to unnecessary steroid, because steroids do have consequences. This is the largest cohort study, comes from US, where 66 patients who had autoimmune hepatitis based on physician's diagnosis, and 164 patients with indeterminate acute hepatocellular injury where there was no hard diagnosis, and 131 where physician diagnosis was drug-induced liver injury, all with acute liver failure were started on steroids. Proportion of them were exposed to steroids, others weren't. If you compare to people who were exposed to steroids, blue, to those who weren't, orange, there was no statistically significant difference in overall outcome. If anything, steroid use was associated with reduced survival in people with more severe disease with a MELD score of more than 40. So you can do harm than good, especially with patients with acute liver failure. So useful to remember that not all good intentions do end up with a good outcome. So steroids aren't really inconsequential interventions. Long-term consequence of drug-induced liver injury is also important. So this is the study which will be published probably in the next 6 months. This was presented as an abstract in EASL. It's relevant because this is a bona fide, I would say, prescription event monitoring. Such kind of epidemiological studies are less often done, which means that we underestimate the potential of liver injury from a drug, which is effective. Another drug called amoxiclav. This is amoxicillin clavulanic acid combination. If you look at, they used computer-generated data in a huge population of 800,000 to identify drug-induced liver injury, and demonstrated that 1.3% of people develop indication for liver transplantation. And if you compare to the control group, there's significantly higher liver transplantation rate or other causes of mortality. This extends up to 2 years, which means that an event which you see as an acute will have consequences up to 2 years. The second point is to look at the risk factors which led to death, liver failure, or liver transplantation. Ethnicity was one of the risk factors. So compared to white population, other ethnicity, which will include Asians, had a higher chance of adverse outcome. Finally, what's in the future? There are large international studies ongoing to improve the diagnosis of drug-induced liver injury in the clinical practice, as well as identification of drug-induced liver injury in drug development, both in the clinical trials as well as in vitro. We are investigating a number of new biomarkers, including the 2 which have been shown in a small pilot study to be beneficial in identifying the prognosis of acute liver injury beyond the tests that we have got. In this study, patients who have high cytokeratin 18 and macrophage colony stimulating factor receptor concentrations are associated with death and transplantation as an outcome, in combination with MELD score. So if you use these markers with the MELD score, you can stratify patients with a very good degree of sensitivity and specificity. And these are being tested in a larger set. And these are another form of liquid biopsy tests, microRNA profiles. This is also from a US study where they identified 11 different microRNA profiles which either went up or down significantly in association with liver injury. And they identified microRNA 1 to 2, a threshold which was sensitive for predicting survival. So in summary, the key points are that drug-induced liver injury is not a rare event, but it's under-recognized. In the context of acute liver injury, it's very important to probe about medication because we don't seem to consider drug-induced liver injury as a possibility, even when the observational studies and epidemiology suggest it is so. Evaluation of drug-induced liver injury should be systematic, not just intuitive, and one should use diagnostics available, including liver biopsy and HLA genotype selectively. There are prognostic implications of drug-induced liver injury beyond the acute event up to 2 years. Steroid therapy has been overused in drug-induced liver injury and can do harm in certain contexts. And because it's still an uncommon event and phenotyping drug-induced liver injury is still not very deep in most circumstances, international collaboration is necessary to research this area and develop new tests and interventions which are benefits to the patients. If you want to hear more about the science, have recorded a public science speech through University of Nottingham. If you follow this link, you might be able to hear the long version of scientific background of how the drugs, both efficacy as well as in its adverse effect, affect an individual, and how we can use this knowledge to develop a better strategy for interventions. Thank you very much. Thank all my collaborators and for Pakistan Society of Hepatology to give me an opportunity to talk to you all. Thank you.